Good afternoon, everyone. Thank you very much for joining us for this update on COVID-19 and MS. I'm your host, Casey Minnis, Director of Communications for the Multiple Sclerosis Foundation. And joining us today is Dr. Ben Thrower. Many of you know Dr. Thrower. He is an expert in MS care. He is the medical director of the Andrew C. Carlos MS Institute at Shepherd Center in Atlanta, Georgia, and senior medical advisor for MS Focus. We're delighted that he was able to do this on short notice to share with you the latest information about COVID-19 as it affects people with MS. With that, now I'll turn it over to you, Dr. Ben.
Great. Thank you, Casey. And so thank you to everyone at the Multiple Sclerosis Focus for pulling this together so quickly. You guys do a great job with the technology. This is a strange new world we're all living in, and we're all becoming Zoom experts, whether we want to be or not. So I really appreciate you guys. I appreciate the technology. What I hope to do today is give just a brief overview on kind of where things are at nationally with COVID, just from a big picture perspective, and then hone in on some topics as COVID relates to multiple sclerosis, and leave plenty of time for discussion, question, and answer. So it's been a long past 4 months. It seems like it's been years since we've been dealing with this. And initially, I would say as of a few weeks ago, it looked like our COVID cases were going down, and here in the past few weeks, they're creeping back up again. There are lots of different ways that we can look at this. So if we look at the percentage of COVID tests that come back positive, that's one way of looking at these numbers. When we think about COVID numbers, some people have thought, well, maybe the COVID cases are going up because we're testing more people, and there is a little bit of truth to that, but the percentage of positive cases are also going up. And I've got some numbers here. So these are the most recent numbers from the CDC. So of the people that have been tested in the United States, as of 2 weeks ago, about 6.5% of the tests were positive. Now we're up to about 7.6% of the cases coming back positive. There are, in the United States, as of today, 258 million cases of COVID, and there have been about 127,000 deaths, unfortunately, from COVID. What is interesting is the geography. So, as the numbers start to creep up in some parts of the United States, they seem to be leveling off or going down in other parts of the United States. So depending upon where you live, people may be in very different situations. One thing that we do seem to be seeing is that the numbers seem to be rising in healthy young people. So when we think about the numbers of cases, we also want to think about what is the real impact of those people who are contracting COVID. How many people are ending up in the hospital? How many people are dying from COVID? And the good news in all of this is that the hospitalization rates for most of the country seem to be staying stable to actually going down a little bit. We need to see how that's going to play out as the percentage positive cases go up. Could we see hospitalizations and death rates going up also? We hope not, but the other silver lining is that the people who seem to be contracting COVID right now, these young, healthy people, are also the group of people who are the most likely to either be asymptomatic or have mild cases of COVID. We have a lot of questions still heading into the fall. We have questions about schools reopening. I don't know how many of you saw yesterday that the American Academy of Pediatrics actually came out with a recommendation that students should be able to go back in person in the fall. And their reasoning was that children seem to be less affected by COVID than other groups. They seem to be a little bit less likely to get it and less likely to get sick from it if they do get it. That's not to minimize the severe cases of COVID in children. There is a syndrome of multi-organ failure that can rarely affect kids and can unfortunately be fatal. So that's not to minimize, these rare cases of severe COVID in children. Part of the rationale from the American Academy of Pediatrics is that we're seeing the negative effects of children on of the social isolation. So we're seeing kids, isolated from their friends, they're isolated from their classmates, their learning seems to be not quite as great online. We should all have a huge appreciation for all of our school teachers out there, because clearly a lot of us are not school teachers, and we can't just jump in and fill that role in the same way that school teachers did. There have been increases in pediatric and teenage suicides, increases in probably some domestic violence, both against children and adults. So that was part of the rationale behind why the Academy of Pediatrics thought it may be wise to go ahead and open classes back up. We have to do this with the realization that there are teachers and staff in these schools who could be in vulnerable populations. So we want to protect those teachers who might have other health problems or who might be older, and look at ways of keeping them safe while we're getting kids back in school. I think we're going to see a variety of strategies of how schools attack this. I know here, for instance, in Cobb County, Georgia, where my wife and I live, they're giving parents the option. They can have either their children go back to a full classroom, 5-day-a-week usual schedule with appropriate social distancing and hygiene in the school, or they can do virtual online training. Once the parent commits to that, I think they're locked in for 9 weeks, that they have to stick with that track one way or the other, barring any other situations coming up. There are a lot of other unknowns. So vaccines for COVID, do we have one on the close horizon? We don't know. There are multiple vaccines that are in testing globally. The protein, the spike protein that these vaccines would be directed against on the COVID virus, that protein appears to be fairly stable. So according to virologists and vaccine experts, they are optimistic that a vaccine will be possible. A note of caution, there have been, so we have COVID antigen testing. So that's the swab that you can get to see if you actually have the virus. And then there's antibody testing to see if you've been exposed to the virus. There have been some small studies that have suggested that maybe those antibodies don't stick around as long as we would like for them to. We hope that that's not really the case, because if our antibodies, our immunity, if it doesn't persist, that's going to have implications for people's risk of getting COVID a second time, or it could have implications for the effectiveness of the vaccines themselves. So that's kind of a global picture of where we're at. What do we know about MS specifically? So early on into the COVID experience, we were making our best guesses about what that would look like. Fortunately, now we do have some data available. One of the important, I think, principles when we think about multiple sclerosis and COVID is I am still running across individuals with MS who are under the mistaken impression that their immune system is compromised from multiple sclerosis. And as most of you know, MS is an autoimmune condition. It's your immune system picking on something that it shouldn't be picking on. And in general, a person with multiple sclerosis doesn't have an underactive immune system. A person with MS has a relatively overactive immune system. So if it's just MS by itself and an otherwise healthy individual that we're talking about, that person doesn't have a compromised immune system and would not, in theory, be at higher risk for COVID just from their MS by itself. Obviously, if we put other health issues, hypertension, diabetes, asthma, COPD into the mix, those conditions do carry a higher risk of COVID. Um, when we think about the therapies, we'll come to that in a minute. How do those change the immune system, and how do those change the risk? One of the, I think, the most helpful registries out there is called COVID-MS, COVIMS. And this is a registry that is trying to collect as much data as possible on as many people as possible with multiple sclerosis and COVID. And I've got some of those most recent numbers, and you can actually go on their website and check them out yourself. So what they do is they break their numbers down into individuals who have laboratory positive COVID, and then those who are just clinically suspected. So they may not have a laboratory proven case, but their symptoms are very suspicious. And when you put those two groups together, it comes out to about 330 some odd individuals, or 276 in the laboratory positive, and 59 in the individuals in the highly suspected group. When we're looking for positives, if you look at this group of individuals with MS with COVID or suspected COVID, 87.5% of those individuals have recovered completely. So that's great news. The not great news is that 6% of those individuals have died. That number is a little bit higher than the COVID mortality rate that we see for the general public. It is possible that there's something called selection bias in these numbers. So when you think about someone who might go into a registry, you could say, well, maybe if I'm a physician and I'm referring someone to this registry, or if I'm a person with MS or a family member or friend of someone with MS, maybe I'm more likely to put my information into this registry if I had a really rough time, if I was hospitalized, if I was in the ICU, or if maybe a friend or family member actually died from COVID. So it is possible that number could be a bit higher because of selection bias. Two of the individuals that are registered that are listed as dying actually did not have multiple sclerosis. They had neuromyelitis optica, the cousin of multiple sclerosis. So if we take those two individuals out, it actually drops the mortality rate down to 5%. So what do we know about the individuals with MS in this registry who died from COVID? What we see is that they tend to have the same risk factors as individuals without MS who have died. They tend to be older individuals. The average age of someone who died in this registry was 65 versus the average age of the people who survived being 41. So over a 20-year age difference between people who died versus surviving with COVID and multiple sclerosis. They were much more likely to have comorbidities. So most of the people that died had other health problems other than their multiple sclerosis. They tended to have more disability from their MS. They tended to be non-ambulatory. So older, more disability, more concomitant illness or comorbidity seem to be a predictive factor. The general consensus is that when we look at this group overall, the risk of serious COVID versus recovery overall does not look significantly different from the general public. And that's been the message that I've been giving out to individuals with MS, is that when we look at a person with MS, I think that we want you to follow the same smart guidelines that a person without MS would follow. So, social distancing where appropriate, mask wearing as much as we can, along the lines of masks. I think it bears repeating that the average mask, the typical masks that all of us are wearing, assuming they're not an N95 mask, they're not necessarily protecting us, they're protecting everyone around you. So it's important that people around you are wearing their mask to protect you. If someone wants to try to protect themselves, that's where you get into the higher filtration masks like the N95 masks, which would in theory offer protection both ways. You will see some of the N95 masks that have these little one-way valves on them. In theory, if that valve is doing what it should be doing, that is letting air directly out, unfiltered air. So in that case, you could say, well, if I'm wearing that kind of mask, I'm protecting me and not you, and that's probably not ideal. So I think if we want to be good neighbors and good citizens, we probably wear our surgical masks, cloth masks that are going to give group protection. If you want to protect both you and yourself, an N95 mask without that one-way valve would offer, in theory, protection both directions. What about the therapies? What about the medications that we have, for MS? So we have a lot of different, really two ways, but a lot of different pharmaceutical companies. So each pharmaceutical company that makes an MS disease-modifying therapy is collecting data to see how people are doing. And then there is data collected in this COVID-MS registry. If you look at people who did poorly, who died from COVID in this multiple sclerosis registry, the majority of them, interestingly, were not on any treatment. And that may speak to the fact that the death was more common in older individuals and who had more progressive disease. So a lot of people with secondary progressive MS may not be on a disease modifying therapy. So that may account for why we see more deaths in people who are not on treatment in this registry. There was no consistent finding in this registry really about one drug being riskier than another drug. Early on into the COVID experience, before we had any data, we had to think about, in theory, how would an MS therapy affect someone's risk of COVID or affect someone's risk of having a bad outcome. And early on, our thought was, well, some of our older therapies, our glatiramer, Copaxone, our interferon therapies, those drugs have been around forever. They're in no way immunosuppressant and really should not negatively impact a person's risk of COVID or how someone does with COVID. There was and still is some interest in interferons because we know that interferons do have potential antiviral properties. So I know there are studies ongoing still looking at interferons as potential therapies for COVID, probably at higher doses than what we would traditionally use in multiple sclerosis. But clearly our old platform therapies, our ABCR drugs, are not associated with a higher risk of contracting COVID or a higher risk of having a bad outcome. Then we get into some of the newer therapies that might have more potent effects on the immune system. And so if we think about some of things like Ocrevus, rituximab, Gilenya, Tecfidera, Aubagio, there was some initial thought that maybe because those medicines have an effect on the immune system, maybe those drugs could actually put a person at a little higher risk for picking up coronavirus, but maybe on the back end, they might protect people from this cytokine storm, this negative immune response where the immune system is attacking the virus, but is also having effects on the lungs and other organs. I would say that from the data we have so far, we're probably not seeing an effect either way. I think the numbers are just too small to say that our more potent therapies put people at risk for coronavirus or offer any sort of protective effect on the back end from coronavirus. So what does that mean in the big picture? How do we advise people with MS on different therapies? So Shepherd Center, along with MS centers all across the country, looked at how these drugs work, and the consensus was we probably wouldn't change how we manage MS or how we dose these medications. I know our policy here at Shepherd looked very much like the policy, say, at Cleveland Clinic or at Mayo, where the thought was we need to continue to manage people's MS appropriately. We need to keep the doors open. We need to keep people safe. And that probably means keeping people on therapy, regardless of whether it's an oral medication or one of the IV medications. So that's the way we've been doing things, with one small exception. So Ocrevus is FDA approved for primary progressive MS. Many of our individuals with primary progressive MS on Ocrevus are in that 65 and over age group. My feeling was that we might want to offer those individuals the opportunity to push their Ocrevus infusions back, and we've done that. Primary progressive MS typically doesn't crash and burn if we delay an Ocrevus infusion. So because many of our older Ocrevus patients with primary progressive MS had comorbidities and were in this higher risk group, we did push some of those folks back. We had individuals early on, particularly in the month of April, on drugs like natalizumab or Tysabri, who said, you know, I'm really nervous coming in, going anywhere. I don't want to go outside of my home. Can I miss a Tysabri infusion? And the answer for most people was yes. So with a drug like Tysabri, we feel that those individuals could safely miss one infusion. We don't want to push our luck much further than that. We know if an individual misses 3 natalizumab infusions, so they're 3 months out, the risk of new lesions on MRI or a relapse goes up pretty significantly. Past studies have suggested that risk might be around 44 to 45%. So it's been an interesting past 4 months. I think fortunately for most individuals with MS, COVID has been scary, but has not, other than the effect on our lifestyle and the ability to get out and do things. Fortunately, I don't think it's changed the health of the majority of people with multiple sclerosis. I would say in our patient population here at Shepherd Center, we take care of about 3,000 people with MS. We are tracking individuals with COVID. We have 9 individuals who have tested positive for COVID. We have had no hospitalizations with it, and these people have all recovered completely, and they are on a range of medications. So we're not seeing any consistent trend one way or the other. I think the next big decision and discussion we will have amongst all of ourselves is when we get a vaccine for COVID. What does that look like for a person with MS? It's really going to depend upon how immunogenic the vaccine is. The majority of vaccines that are used commonly have been well studied through the CDC and National MS Society and are felt to be safe for individuals with MS. So for instance, the seasonal flu vaccine. There are a handful of vaccines that are very, very immunogenic. They generate a big, angry immune response, and we wouldn't want to see those given in a person with MS. So the two most that come to mind to me would be yellow fever or Japanese encephalitis. Fortunately, these are not vaccines that most people in the United States really need to think about, but those would be vaccines that generate a big immune response and have been shown to actually definitely cause MS relapses. My suspicion is that when and if we get a COVID vaccine, is that it's going to look more immunogenically like a seasonal flu vaccine. That my suspicion is it's going to be safe for people with MS. If by some chance it turns out to be more immunogenic, we're just going to have to cross that bridge when we get to it. There obviously is a big push nationally for this to move very quickly. There's a lot of funding, a lot of motivation for multiple pharmaceutical companies globally to get this done. And there are several vaccines in phase 3 testing. To get a vaccine out quickly, we by definition are not going to have years and years of safety data on that vaccine. So there will probably be some unknowns once that vaccine is approved and ready for use. The other thing that we discussed earlier is do we know that the antibodies that are generated by that vaccine are going to be long lasting? And that's the only way that we're going to know that is to study people for long periods of time to see how long that immune effect lasts with the vaccine. I think the last thing that I would just throw out there, and this is kind of a quirky one, just in case we have anyone in the audience who is on IV immune globulin. IVIG is not FDA approved for multiple sclerosis, but there are individuals who are on IVIG. Maybe they've tried other things and had side effects or didn't have a great benefit from a standard FDA approved treatment option. So they end up on monthly doses of IVIG. I think IVIG is going to be interesting to watch because IVIG is pooled antibody from a large number of blood donors. And as more Americans get antibodies to COVID, it is very likely that those antibodies are going to show up in IVIG. Does the person with MS who's on monthly IVIG then get passive immunity from all of these other blood donors? There's a real world example of that. So if we have an individual with MS who's received IVIG, we can't rely on JC virus antibody testing because that individual who's received IVIG will be JC virus antibody positive because they've just gotten antibodies from probably 250 other individuals. And we know a good chunk of those, probably 50% of those individuals are JC virus antibody positive. So that same thought is probably, I believe, could possibly happen with individuals with MS on IVIG in a good way, though, if they get passive immunity through transference of protective antibodies through their IVIG. We'll have to wait and see how that happens. For that to happen, in theory, we would have to have herd immunity. We would have to have probably 70% of the US population positive for COVID antibodies. We are nowhere near close to that. I haven't seen the national numbers, but in the state of Georgia, the percentage of people who have been tested for COVID antibodies who come back positive for those antibodies is only about 6%. So it's still fairly low. With that, Casey, I think I'll throw it open to the audience if we have any emailed questions or on live questions. Happy to talk about whatever people want to cover.
Okay. We do have questions. Let me just instruct our audience if they would like to ask their own questions. They can use two different methods to send a question in. You can use the chat feature in Zoom. If you touch your screen or click on your screen, depending what kind of device you're using, you'll see a little chat bubble. If you open that up and just type in your question, or they can use the raise hand feature where you'll see the more button on your toolbar with the ... And if you click there, you should have the option to raise your hand, and then I can bring you on the line to ask your question live. All right, our first question, you mentioned one off-label treatment, the IVIG. There's another off-label treatment that we have a question about. That is LDN, or low-dose naltrexone. Eileen says, I'm on naltrexone for MS. I do know it's not an immune suppressant, but I also know that MS patients can die from complications due to viruses and diseases. I'm wondering how this will affect me.
So I wouldn't expect low-dose naltrexone to have any negative effects as it relates to COVID. So for anyone who's not familiar with low-dose naltrexone, so naltrexone is the FDA-approved dose is given as a 50 milligram tablet as an opiate receptor antagonist. It's used to help get people off of prescription painkillers if maybe they have an addiction. It's actually sometimes used in alcoholics to help kind of detox from and break that craving for alcohol. The thought in multiple sclerosis is by using a very small dose, 4.5 milligrams, sometimes 3 milligrams, thus the name low dose naltrexone, that we're partially blocking opiate receptors and we're forcing the body to make natural endorphins, and that those natural endorphins could do a couple of things. Early on in the low-dose naltrexone story, there was a lot of, I would say, hype about maybe it having very potent immune effects, and that hasn't really been borne out. But what it does seem to do in some people, by increasing those natural endorphins, people sometimes have better energy levels, better pain control, So based upon increasing endorphins, I can't really think of any way that that would have a negative impact on someone's risk of COVID or risk of having a bad outcome with COVID.
Okay. Our next question is from Jennifer. She says, question, does the COVID-MS registry only contain data that individuals self-report, or are providers also reporting this data on their patients?
So the COVID-MS database is self-reported, but I suspect what's happening in some cases is the healthcare team is probably helping the person enter that data. For instance, if it was someone who had more physical limitations or maybe some cognitive challenges, I would imagine that the healthcare team, case managers, are helping enter that data into the database. So what we're doing right now is we're making our patients who have had COVID aware of that database. All of our individuals have been minimally affected from their MS, and so they would be capable of doing that on their own. We are collecting the data on a spreadsheet ourselves. So if we find that they're not entering it, we can always go back with their permission and in a redacted fashion enter it for them if they would like.
Carol from Roswell, Georgia, has several questions. She says, I have relapsing remitting MS and I'm not on DMD. Is it okay to go to the lake over the 4th of July holiday wearing a mask?
Yeah, so hi, Carol. So a lot of this comes down to individual risk tolerance. There's a lot that we know about COVID and there's a lot that we don't know. And at the end of the day, I can't tell someone that if you go to the lake on the 4th of July that you have a 1% chance, a 5% chance, a 10%. We just don't know. So what we do know is that, when we look at large outdoor gatherings, it seems like that's not the primary way that COVID is being transmitted. I would worry a lot more about someone in a large indoor gathering, going to a coliseum, an arena where everyone's packed in. I think it's going to be a much higher risk situation for individuals. We've just had a lot of, social unrest. We had a lot of outdoor demonstrations and protests, and no one that I have, none of the experts that I have spoken with has said that we're seeing a big spike in COVID from those situations. And that's hard to tease out because people do a lot of things. So maybe someone went to a demonstration and then they also went to a nightclub. Where did they get their COVID from? Was it the nightclub or the demonstration? I would suspect it was probably more the indoor activity versus the outdoor activity. So it's hard to give someone an exact risk number. I think there is a lot of benefit to getting outdoors and at least getting some sunlight, because we are seeing people suffer from the social isolation. I think so. If you were my family member, would I say, if you're with a small group of people, you're socially distanced, you've got a mask on, you're outdoors, I would probably be okay with someone doing that, just for the happy factor of being able to get outside and do something.
Okay. Carol, we'll come back to more of your questions if we can. We've got quite a lot in the chat, so I want to give everybody an opportunity. Chantal says, my boyfriend has MS and just has tested positive for COVID-19. Should he stop his Gilenya?
So no, I would not. So there is risk of stopping Gilenya, and I would argue that there's more health risk from stopping the Gilenya than there is from staying on it. Again, when we look at in fact, I've got the numbers here, the COVID-MS registry, Gilenya, there was not a death on Gilenya within that registry. I know that Novartis is collecting data, and there has been nothing that we've seen that would say that you are more at risk for a bad outcome by being on Gilenya. So I think the risk of MS flaring up, and then also the other thing I have to factor in specifically with Gilenya is that if you go off for more than a certain period of time, you've got to do that first dose observation again when you restart it. So, however he did that, whether it was through sitting in a cardiologist's office, so he's got that cardiac observation. That could be challenging right now. I've not had experience with that, but and maybe Novartis is making some special accommodations. I imagine getting into a cardiologist's office to do the first dose observation could be challenging, so they may be doing it more home-based. So I would say no, don't stop your Gilenya.
All right. Tony asks, kids are being prompted to go back to school. They have a lower risk of COVID mortality, but is their risk of transmitting COVID any less?
Yeah, so we don't know for sure, but it appears to be very low. So there was a study about a month and a half ago out of Iceland where they looked at their school-age children. They could not identify a single case in the entire country of Iceland of a child transmitting COVID to an adult. That's reassuring. Again, it's one country's experience, but it does appear that the risk is fairly low. That was a big concern early on, is that our children basically going to be these little asymptomatic vectors. So they're running around fine, but they're giving it to grandma and grandpa and getting everyone else sick. So far, it looks like the risk is low, but I think we still want to have a healthy degree of caution when the schools reopen. I think that administrations hopefully are going to be very adaptable. So if you have older individuals who are teachers or administrators or staff, maybe we can keep them on a work from home basis. I know what we're doing here at Shepherd is being pretty liberal with letters that we're supplying to individuals with MS and saying, listen, I can give you general guidelines, but I can't give you absolutes. If your employer has any option for you to work from home and you feel more comfortable working from home, by all means, we'll write you a letter to work from home to accommodate you.
Our next question is from Giselle. She says, I have a dentist appointment for cleaning and an eye appointment to check glaucoma. Is it safe or should I cancel?
Oh boy, those are tough ones. Glaucoma, my recommendation would be not to cancel that. Keeping your eye pressures under control, I think is really important. And so glaucoma is still the leading cause of blindness in the United States. Going months and months with an elevated intraocular pressure could lead to permanent visual loss. So I think there, and just the nature of ophthalmology appointments, I mean, that could, they don't have their hands in your mouth, hopefully, unless you've got a strange ophthalmologist. But I think that could be done safely. The dental thing I struggle with, when you look at all of the healthcare occupations, dental hygienists are listed as having the highest risk of picking up COVID. So if they're at the highest risk for picking it up, that could go the other direction too, just by the very nature of a dental practice. It's up close and personal. Saliva is getting aerosolized. I know that the dentist offices have changed a lot of their procedures. They're doing cleanings in a different way. They're not using a lot of the high pressure sprays. I think waiting 6 months on a dental cleaning is probably okay. Again, it's all about risks and benefits. Me personally, I would wait 6 months. Hopefully there are no dentists in the office or dental hygienists who are going to come hunt me down for saying that now. But I would wait on the dental cleaning.
Okay, our next question is from Judy. She says, can COVID put someone with MS into such a hyperimmune response that it looks like a relapse neurologically, such as vertigo or facial numbness? How would you tell with unconventional symptoms of COVID?
Yeah, that's a great question. So I think that, COVID is a virus. And so any viral infection, influenza, common cold, any viral infection that revs your immune system up a little bit, it has the potential to cause a pseudo relapse or a pseudo exacerbation. And we know that, as your immune system revs up to fight off that virus, old MS symptoms can flare up. And then once the virus is cleared, those old MS symptoms are going to typically quiet down. So if you had a more severe case of COVID, with a cytokine storm and it's kind of hyperactive immune response, could you have even more neurological symptoms? I think it's certainly possible. I would argue if a patient is in that sort of situation where they've got a cytokine storm, there probably going to be a lot of other things going on. And how we might manage an MS relapse with steroids, you know, might might sort of blend into how they're managing the severe COVID complications. I, I I've not so I know there was a big Italian database. They looked at their MS patients. We've got the COVID MS. So far, teasing out what's MS versus what is organ damage from the cytokine storm from COVID has not changed the way we think about managing people. And I think at the end of the day, if someone is in that situation, what COVID is doing to other organs is probably going to be prioritized over a possible MS, exacerbation.
All right, thank you. DM says, thank you, Dr. Thrower. You mentioned pushing back infusions for older PPMS patients. What kind of delay do you generally apply?
So, our hope early into this was that maybe COVID, the pandemic, was going to be quieted down by the summertime. So we were initially thinking 3 to 4 months. That's obviously, it's gotten more difficult as this smolders along. So I think that it can be done in a primary progressive MS patient can have their Ocrevus delayed by 3 months pretty safely. So at some point, the human immune system is going to start repopulating the B cells that Ocrevus has depleted. That varies a lot from individual to individual, but at 9 months, I would say most people are going to start repopulating. So 3 months has been my comfort level in primary progressive MS. I think there are going to be individual mitigating factors. How many comorbidities does a person have? What sort of response did they see with Ocrevus? I mean, I have seen individuals with primary progressive MS who were kind of on the fence as to whether it was really doing anything or not. So maybe if you're in that situation where you're thinking, you know what, I was never that convinced that it was really changing my course of my primary progressive MS, and now I'm 3 months out and I really can't tell a difference. Maybe in that individual, if there are other comorbidities, maybe we push it out a little bit further. So I think it's going to be very individualized in terms of what goes into making that decision.
Okay. Now we have a few questions about vaccine. The first is from Nicole, who asks, once a vaccine is created, who will notify people with MS that it is safe to take? Are neurologists, MS Focus, MSAA, etc.? Who do we look to for an answer?
All of the above. So I think, for us here at Shepherd Center, we would post something, on our sort of social media. I would look to all of your usual sources of information, MS Focus, the MSAA, the National MS Society, all of those organizations, I think, are going to be on top of this and really trying to get information out to people as quickly as possible. I think the harder question is what's the threshold to say it's safe for a person with MS? So I think, early on, it's going to be like COVID was early on. It's going to be very theoretical. It is very likely that in the phase 3 studies of these vaccines, that people with autoimmune diseases may not be part of those studies, because that's the way studies run. They pick kind of the 18 to 55-year-old person with no health problems typically. So it is possible that we may be making an educated guess on what the vaccine looks like in a person with an autoimmune disease. So, at what point do we feel that those are safe? I think that's, just like we're talking about comfort levels with different activities, that discussion is probably going to look very similar. We're going to talk about what do we know absolutely, what do we know in theory, and what's your comfort level, and how do we sort of come up with some sort of risk-benefit ratio. If let's say it's February of 2021 and we have a vaccine, and now COVID has just run rampant through the United States. But the silver lining is that now 70% of the US population has antibodies. And we now have some indication that those antibodies persist and that it's to some degree protective. Do we let vulnerable populations, maybe we're not convinced of the safety of a vaccine in a person with MS, do we let people with MS sort of benefit from the herd immunity? We just say, okay, most people have immunity to it, therefore your risk of contracting it in the public may be lower. I think those are going to be the discussions that occur. And so there's so many moving parts to that we're just going to have to see where we're at once the vaccines come out.
Okay. And we've also had several people ask for clarity on the flu vaccine, whether that's something that's safe for people with MS, whether it's something people with MS should be taking, and whether any of the medications affect the issue of whether or not they should have the flu vaccine.
So in general, the flu vaccine is safe for people with multiple sclerosis. So, there was a lot of sort of misinformation years ago, and there many years ago with the swine flu, that was a bad vaccine. So the swine flu vaccine was associated with things like Guillain-Barré syndrome, and that was a bad vaccine. So both the CDC and National MS Society have guidelines on the safety of vaccines for people with MS. And so we know that the influenza vaccine is in the form that we use now is safe for people with MS. Should a person with MS get it? That's a tougher one. So we all have to kind of make that decision on an individual basis. So some of that depends upon what your risk of influenza is. If you're a school teacher, a nurse, a healthcare worker, where for instance, healthcare workers, usually you're mandated to get the flu vaccine. So for instance, everyone here at Shepherd, every employee from housekeeping on up is going to get the flu vaccine if we want to work here. Teachers, I think, again, where you've got a lot of exposure, I would say to do it. If you're, really not going outside of the house very much, you've got very low risk, everyone else in your family has been vaccinated, so you've got herd immunity of your own little mini population, maybe there are individuals that can do without it because their risk of exposure is low. So the medicines that could potentially affect the flu vaccine would be our anti-CD20 monoclonal antibodies. So rituximab and Ocrevus, in theory, could affect the effectiveness of vaccines. And there actually have been studies that have looked at this. The Ocrevus and Rituxan don't make the flu vaccine ineffective. They might make it a little bit less effective. So vaccines are designed to produce antibodies to whatever you're vaccinating the person against. About 6% of Ocrevus patients will have decreased antibody levels. And so that's probably your group where you're going to see maybe an Ocrevus patient not getting as much of a bang for the buck with their vaccine. Doesn't mean we don't do it. There is also a timing factor for people that are going to be starting Ocrevus or rituximab. In general, if you have vaccines that need to be done, you'd like to have them vaccinated about 6 weeks prior to starting Ocrevus or Rituxan. Once the person's up and running with the drug, in theory, their immune system probably is in the same place, throughout the course of their drug. Most MS centers check immune function before we give a dose of Ocrevus, at some point, maybe in between doses. And what we'd like to see is that the person's immune system is kind of staying in a stable place. So once a person's up and running with a drug like Ocrevus, that timing of a vaccination may not be as critical. I hope that helps.
Now we have a couple of questions about masks. ESS says, I take Ocrevus, next infusion is July 17th. I have to go back to work in a high school starting July 27th. I've not disclosed my disease to my work. My neurologist mentioned wearing an N95 mask. Am I safe to return to work? My husband thinks an N95 mask may be too difficult with fit testing on a daily basis and wearing it all day.
I will say the N95 masks are not fun for most people. So they are pretty hot. I would I think a lot of people would struggle with wearing that 8 hours a day, every day. You talk to nurses who went up and worked in some of the hard hit areas like New York City, and I have a lot of friends who did that, and they said it was not fun to do. So again, when we think about your Ocrevus infusion, so far what we're seeing with Ocrevus is that your risk of picking up COVID or having a bad outcome with COVID does not appear to be significantly different than the general population. I'll throw in an interesting sort of contradiction, and I'm not sure quite what to do with this. If you go to the National MS Society website, they contradict what I just told you. Their website says that there may be a slightly higher risk of having a bad outcome from COVID if you are on Ocrevus or rituximab. I'm not sure where that thought came from, because really we've only got two sources of information to think about Ocrevus and COVID. We've got the data from the drug manufacturer themselves, and we've got the COVID-MS database, and neither of those sources would suggest that people on Ocrevus are behaving differently than the general public. So I appreciate everything the National MS Society does, but I'm not sure why they've got that position paper in there. And I know Genentech's working with them to try to clarify that. So I would say, your risk really should not be higher than the general public when you go back. Would I wear an N95 mask if I were you? If I could find one that was comfortable and practical, I would. I would just try to make sure all of the adults around you are wearing face masks. I think most of the school districts are going to strongly suggest, if not outright require that, so that you're protected from other people. And then hope that what we think about children transmitting to adults is really true, that it appears to be a very low risk of transmission from kids to adults.
Our next question is from Alethea. She asks, is a KN95 mask as good as an N95 mask? What's the difference? And is a double cloth mask as good as a KN95?
So the KN95 and the N95 are in theory the same thing. They are supposed to offer the same degree of filtration. The KN95 designation is what China uses. So if you see a mask labeled as KN95, it came from China. That's the nomenclature that they use. We're a little nervous about the quality of some of the products coming out of China. So when I say in theory they should be the same, some of the PPE that came from China to other countries early on in the COVID pandemic had to be sent back because some of the products coming out of China were faulty. So if a KN95 is what you have access to, I would say use it. I would prefer an N95 to a KN95 if I can get one. When we think about cloth masks, that's where things really get tough, because there's a lot of different types of fabric out there. And there's some interesting studies looking at the effectiveness of filtration from different fabrics, ranging from, to cotton to, heavier quilted fabrics. And it does appear that some of the heavier quilted type material is more effective at filtration. That's a hard one. I would be surprised if you had a truly high quality N95 or KN95 mask if the double cloth mask would be as effective at filtering as that. And again, remember, with most of your cloth masks, you're wearing those not to protect yourself, you're wearing those to protect other people. So if everybody has a good cloth mask, in theory, we're all protecting each other. Whereas with the N95 or KN95, assuming it doesn't have that one-way valve allowing bad air to go out, the N95 or KN95, in theory, you're protected both ways. You're protecting yourself and people around you.
Now we have a few follow-up questions. You spoke earlier about an appointment for glaucoma. Alethea asks, what about regular vision care appointments? Is that relatively safe?
Regular visual care, I think, there again, the contact, the proximity to people, the amount of touching that's done, I wouldn't worry about that probably as much as a dental appointment. So I think that people can safely keep those.
Okay. And we talked about masks, but here's a question about people not wearing masks. Can I have a few friends over if I keep 6 feet away if we're not wearing masks?
I would say not if they like you. I would, there's just so much unknown. And in the big scheme of things, wearing a mask is just not that big of a deal. Now, granted, if you're having wine and you're eating, you can't eat and drink through the mask. So, I mean, having it off while you're eating and drinking when you go to a restaurant. Obviously, people in restaurants are not able to eat with a mask on, but all the servers and staff should be wearing their masks. I would say if you're having a gathering, try to keep 6 feet apart. If you're not eating or drinking, keep your mask on. When you're eating and drink, do your thing and then get them back on. I think, as I think all of us, healthcare providers, the public, we need to have a healthy degree of humility in the face of this virus. There's a lot that we don't know. None of us have ever lived through anything quite like this, and I think a healthy degree of just caution and humility are warranted.
And speaking of caution, you spoke about the 4th of July gatherings and said if it's outdoors and keeping it small. Betty followed up with a question that says, if a group is limited to 30 people who do not all follow CDC guidelines but are healthy and interact regularly, what is your advice about attending if well masked and careful about distance?
So I think if everyone's masked and distancing apart, again, um, in a perfect world, you'd say, okay, well, everyone get a COVID test before you go. Everyone do a temperature check, and temperature checks are not crazy. I will say here at Shepherd Center, everybody that comes in the building has a questionnaire before they come in. And everyone gets a temperature check before we enter the building. Um, so I think that gathering of 30 people, as long as you can keep people, um, masked and socially distanced, is probably going to be a lower risk proposition. Um, it's such a strange virus because some of the cases that we're seeing, New York City reported this. You had individuals who did all the things they were supposed to do and had minimal outdoor exposure who were picking up COVID. And the question is, well, how'd that happen? Where, these people that played by the rules, where are they getting this from? So again, I think there's a lot of questions. The World Health Organization, as you know, about 2 weeks ago, came out and said that they thought that transmission amongst asymptomatic individuals was very, very low. And then they reversed that 24 hours later and said, no, we didn't really mean to say that. What they were basing that statement on was a study, and it wasn't huge. It was about 140 people, I think, that did suggest that asymptomatic transmission, at least in that group of people, was low. So, again, we're getting so much conflicting information that I think that it's hard to come out with these very black and white guidelines. And I think all of us ultimately are going to have to say, well, what do we know? What do we not know, and what risk am I willing to put up with, and realize that when I'm making decisions, I may not be just affecting me, I may be affecting a big circle of people around me. And so that's the challenge. For instance, I ride a motorcycle. If I choose to not wear a helmet when I ride my motorcycle, which I don't do, but if I did, I'm only going to hurt myself if I have a crash. That's not what we're dealing with. The analogy would be, well, if I'm not wearing a helmet, but I explode on impact and I take out, 3 motorcycle riders around me, well, that's probably more analogous. So we're not just dealing with our health and our risk benefit analysis, we're dealing with people around us.
Okay. Um, let's see. We have time for just 1 or 2 more quick questions. Um, Carol asks, I live in a townhouse community and no one is wearing masks at the pool. If I get there early and no one is around or very few people, is it okay to swim a few laps?
I think so. You get there early, and again, that's where you're kind of looking at the risk benefit. You know, the benefit of getting some exercise. You know, again, the happy factor of doing that. As long as there aren't a bunch of people already down there. Obviously, it's difficult in the, at the pool. You could wear it while you're sitting out there. In the pool, obviously not. But I think that would be absolutely fine.
Lisa says, I'm a caregiver for my 17-year-old son who tested positive for COVID. He's upstairs, but can go out the back door with a mask. Do I need to wear a mask if I enter the room he walked through to exit the house? How long does it take for the air in that path he walked to be clear?
Boy, I wish I had a great answer to that. And so, the people have really tried to look at that, at how long aerosolized COVID, stays up, just hangs there. In theory, if he's wearing a mask, and so I guess though she's going into the room after he's not maybe had a mask on, that's a tough one. I think I would probably have her wear a mask anytime she's somewhere where he's been, just to be on the safe side. We have had several situations like that where one family member has COVID, and I would say we've had many family members very successfully quarantine within their own house and have the affected family member not infect other people. My wife's office has a staff member who managed to quarantine within her own house and did not affect other family members, and we've had staff members here do the same.
Okay. And one last question from Scott. Is it possible to contract COVID from food, as in eating takeout? And Carol also asked about that and said, how do you know if the delivery person may be asymptomatic? Is it safe to get takeout and delivery?
So the CDC says that takeout food or getting groceries, delivered to your home appears to be a really, really low risk for transmission. So I think that would be very unlikely that someone in food prep that would cough on your food or sneeze. That doesn't appear to be a major vector for COVID, or that your delivery guy was asymptomatic, breathed on your food. I'd feel pretty comfortable with takeout food or grocery delivery. I personally don't see the need to wipe everything down that comes into all of the groceries. I think that's overkill. I would say my wife and I are not doing it. We go to the grocery store. We're not wiping everything down when it comes back in.
Okay. Thank you so much, Dr. Thrower. I'd like to say thank you to all of our participants. Thank you so much for your time, your attention, your questions, and especially thank you to Dr. Ben Thrower of the MS Institute at Shepherd for making the time to go over this important and timely information with us. Thank you very much, Dr. Thrower. And if any of our audience members would like to unmute themselves and offer their thanks, you're welcome to do so.
Thank you.
Thank you all.
Thank you.
Thank you. Thank you. Thank you very much.
Appreciate it. Thank you.
Thank you.
Thank you.
Bye.
Thank
you. Thank you.
That's a lot of thank yous.
Thank you.
Casey, I have a question for you. Was this recorded by chance?
Yes, this presentation was recorded and will be available on the Multiple Sclerosis Foundation's YouTube channel. If you need a link to that channel, you can just reply to the email that you got with the registration for this event. That'll come to me and I will send you out the link.
Outstanding. I'd love to forward it to my people. Thank you.
All
All right.
Thanks, Casey.
Thanks, Doctor.
Thank you.
Thanks so much, Dr. Ben.
Thank you. Thank you.
Goodbye, everybody, and have a good night.
Bye.